physiology, which is the most exciting part of physiology for the entire course. We will go through a number of topics, which I'll be sharing with your class rep to share with you, because the timetable seems to indicate just cardiovascular physiology. We do have up to about 11 topics. We have been allocated sufficient time. We should be able to finish all of them. I'll welcome you to participate as much as you can during the sessions, not necessarily live. There will be a session towards the end, about 5 or 10 minutes. You can ask questions, and I'll also welcome you to send your comments via email, which I'll provide. So my name is Dr. Fred Bukachi. I am the immediate former chair of the Department of Medical Physiology. I'm a practicing cardiologist when I'm not teaching cardiovascular physiology in Chiromo and the School of Medicine. This time round, we'll go through circulation and pressure flow dynamics. We'll spend the next 40 or 45 minutes just looking at the introductory aspects. Once we finish that, I'll then allow you to go and review the information given as preparation for the future topics. First of all, for this evening, the objectives are as follows. One is to understand the general organization of the circulatory system. Much of this will be high school review of what we already know about the circulatory system. And then number two, a look at the cardiac structure and function, again, reflecting on the anatomy of the heart and the vascular system. Much of it you covered last year in anatomy, and also look at some functional aspects. So this is going to be more of the cardiac anatomy that is important for understanding physiologic function. And then we'll get into the main topic, which is looking at the concepts of flow, pressure, and resistance. Again, much of this will draw from our knowledge of physics, and then build our concepts into understanding the relationship between blood pressure, peripheral resistance, and cardiac output. And then much later, most likely not today, we'll be looking at the concept of blood pressure. We'll define what blood pressure is, how we measure blood pressure, and also some of the factors that affect blood pressure. So this is a simplified diagram of the cardiovascular system. First of all, you recognize what is familiar to all of you, and that is the red blood and the blue blood, as you are taught right from primary school in basic science classes, in which case the red blood denoting blood that is oxygenated, and the blue blood indicating blood that is deoxygenated. More importantly for us to recognize, we have two pump systems. One pump system on the left side, usually conveying oxygenated blood, and the other pump system on the right side, essentially conveying blood, receiving blood from the body through the right side of the heart into the lung for oxygenation. And then essentially, again, just reflecting the fact that we have a pulmonary circuit and a systemic circuit, and usually blood is carried by different caliber blood vessels, the red blood or the oxygenated blood being carried by the arterial system, ranging from large arteries, arterioles, and the smaller vessels, the capillaries. And then you have the venular capillaries that again tend to grow into different calibers, into small, medium, and large-sized veins that convey blood back to the heart. So that is essentially the structure, the overall structure of the vascular system. The diagram in front of us shows a number of ultrastructure details of some of the important cardiac structures that we need to reflect on as we grow our knowledge in terms of understanding the function of the heart. First, if you really want to understand the cardiac structure, always we prefer you begin looking at it from the outside to the inside. Remember, the heart is covered by a pericardium, which has two structures to it. You have a parietal and visceral pericardium. In between, there is a fluid, which is the pericardial fluid, estimated about 50 ml at maximum. And the function is lubrication. It also has an immune function amongst, and often in different disease states that we're going to cover. For those of you doing medicine in year 4 and 5, we'll be covering some of the diseases that affect the pericardium, making the fluid to increase, and also increasing to the extent that may be able to compress the cardiac structures. And then from there, we get to the musculature itself. So we have the cardiac muscles, and as you learned in anatomy, 3 different layers of muscles. We have muscles that are circular, oblique, and longitudinal. The longitudinal fibers tend to lie right below the endocardium. So we refer to them as subendocardial fibers. They tend to run from the base of the heart, which is this level here. You covered that in anatomy. Just remember the base is at the level of annulus fibrosus, the structure that anchors the atrioventricular valves and also acts as an insulator for the atrial structures and the ventricular structures. So the longitudinal fibers run from the base of the heart to the apex, and those fibers, as I did say, are subendocardial. And then obviously we have the endocardium itself, which covers the inside of the ventricles, both the left and the right ventricle. And then papillary muscles, chordae tendineae, I'll show you ultrastructure in the next few slides. And then of course, the structure of the atrioventricular valves. Notably, you recognize the yellow structure running just within the subendocardial region. And this particular structure here is the conducting system of the heart. Again, we have a full topic to cover the conducting system of the heart, which will allow us to understand the electrical origin, activation, and flow through the heart to activate the muscle. We covered part of that during the cardiac muscle physiology, but we're going to go through details during this particular topic. So again, just to emphasize structurally, the conducting system of the heart is usually a subendocardial structure, runs just below the endocardium. And then following that, we have the valves. And in terms of the valves, I'll be happy just to remind you this way to remember about the valves of the heart is to divide them into 2 sets. One is the inlet valves and the outlet valves. So the inlet valves will be the 2 atrioventricular valves, that's a mitral valve on the left side and the tricuspid valve the right. The reason we call them inlet valves is because they allow blood into the ventricles. And then we have another pair of outlet valves. On the left side, we have the aortic valve, and on the right side, we have the pulmonary valve or pulmonic valve. So it's important to recognize the first pair, inlet valves, and then the second pair as the outlet valves. May I repeat again about the inlet valves, or at times referred to as atrioventricular valves because they partition the air from the ventricles, and the 2 valves have got unique characteristics. We won't go through the specific anatomy here because you covered it, but just quickly to recognize the mitral valve is one of the most important valves in the heart. It's usually a bileaflet valve. You have an anterior leaflet and a posterior leaflet. And whereas the tricuspid valve, as the word suggests, is a tri-leaflet valve. You can look at the anatomy in more detail for purposes of revision. A few more words about mitral valve. Just look at the structure of mitral valve. If you were to put this upside down, it would look like a bishop's hat. So in fact, it got its name from the French word maître, which refers to the bishop's cap. This would be the point at which the bishop will put this cap on his or her head, and then you have these straps, which are the codi, looking at the spikes that would usually decorate the bishop's cap. And then obviously you have papillary muscles. Again, we won't go through the reflect on your anatomy and revise that to know how many papillary muscles we do have. And then obviously the same ultrastructure is reflected the other atrioventricular valve. So may I then, having spent time on the anatomy, just look at additional information. I'm afraid this clip is not able to play, but this clip best looks at, it's an anatomical clip, the ultrasound of the heart, the ultrasound of the heart showing the 4 chambers of the heart. So fortunately, the clip is not able to play on this device, but it's more or less upside down. This is the mitral valve, over here, tricuspid valve. This is the left ventricle, that is the left atrium. This is adjacent right atrium, and that is the right ventricle. Interventricular septum, interatrial septum. So unfortunately, it's not able to play, but I should be able to play this loop subsequently. We do use this technology every day in our practice as cardiac physicians looking at the heart. We can be able to measure the size, the motion, the integrity of the valves. That is, if there is any backflow, regurgitation, if there's any thickening, if there are any masses. So it's a very intelligent, intuitive technology that allows us to look into the heart. We can measure the efficiency of contractility, among many other measurements that we perform. And those of you doing medicine, when you come to clinical ERs, we should be able to allow you to have a look at how this technology works. We also invite students during holidays to join us during clinical hours to be able to be exposed to these technologies. When we examine the heart using these technologies, we usually reflect on the anatomic structures for descriptive purposes. Just remember that the apex of the heart would be this particular point of the ventricle, and anatomically this is usually found from topographic anatomy. Fourth is left midclavicular, fourth or fifth intercostal space to be able to find the maximum impulse point of the apex. So when we begin to image, then we know clearly that the apex will be at that point. On the imaging frames, normally we flip the images, say up down, for purposes of easier analysis in adults. So that becomes the apex, and the base obviously is the point or the hinge point of the atrioventricular valves. And just remember that this base is formed by the annulus fibrosus, which you covered during anatomy. So that is a review of the anatomy of the heart and the relevant structures that will allow us to understand the next parts of the lecture. So let's then look at the relationship between these 3 aspects. One is blood pressure, blood flow, and resistance. Now, may I pause for a moment to just reflect on the laws of physics, and also out of common sense, just begin to reflect on flow dynamics, which means behavior of fluids through a pipe or behavior of fluids on the Earth's surface. The example I always try to give is crossing the river between Chiromo campus and the playing fields. When you get to the bridge, you get a sense that the river is flowing from a higher place to a lower, from a lower place to a higher place. But in fact, that is not true. flows from a higher altitude to a lower altitude. This feeling that the river is flowing towards Museum Hill, which looks to be higher area. But in fact, in terms of flow, fluid will flow from a higher altitude or pressure zone to a lower pressure zone. The same rule applies in the vascular system. We expect the heart to represent a higher vascular zone and all the peripheral vessels to represent a lower pressure zone. So pressure will flow from the heart, or the blood will flow from the heart, so to speak, towards the peripheries. So if you were to apply the laws of physics, for instance, looking at this tube over here, something applied in plumbing, in hydraulics, and so on, to some basic principles. So P1 will be 0.1 within a vascular system or a tube, and P2 will be 0.2. Of course, P1 representing pressure at 0.1 and P2 pressure at 0.2. There has to be a pressure gradient between P1 and P2 for fluid to flow from P given, and that's a basic law of physics and also basic law of common sense. However, as the flow continues, or as fluid as blood flows from P1 to P2, the velocity will decrease. And the reason the velocity will decrease is because blood or fluid will be subjected to resistance all across the tube. Therefore, if we were to measure pressure at P1 and pressure at P2 and velocities, they would also be different. So in terms of the physical law relationship between flow, pressure, and resistance, usually flow is usually equal to delta P, which is the difference between pressure at 1 and pressure at 0.2, which is P1 minus P2, divided by resistance. I hope I'm not bringing back bad memories from physics. Some of you may quickly recognize this formula from the laws of physics, or when you are covering electricity. So this is the basic principle that we use in determining the relationship between blood pressure, cardiac output, and total peripheral resistance. But this is explained from basic principles following the rules of flow dynamics or behavior of fluids in the vascular system. May I quickly then look at a number of parameters that are important, or definitions. We'll begin by looking at cardiac output, which is defined as the amount of blood ejected by each ventricle per minute. Please note what the definition is, because examiners love to ask this question. It is the amount of blood ejected by each ventricle, not the heart, as a number of candidates tend to write. Then we have stroke volume. Stroke volume is the amount of blood ejected by each ventricle per beat. That's every time you have a contraction of your ventricles. There is a specific amount of blood that is ejected per beat. So we refer to as stroke volume. Now remember that the amount of blood ejected by the left ventricle and the right ventricle is equal, and the contraction tends to happen almost simultaneously. There will be a few exceptions we're going to discuss much later when we look at disease states, but for now, in terms of setting the basis for physiological explanation, both sides are equal. Then we have the preload, which is venous return. That's the amount of blood returning to the heart. If you remember the original diagram I showed you here, that is the blue side of circulation coming into the heart via inferior vena cava for the lower part of the body and superior vena cava for structures that are around the head and neck. And then we have afterload, which is the terminology we use to explain the resistance or total peripheral resistance. That is the resistance that is exerted on blood flow as it leaves the heart, right from the aorta all the way down to the arterial system and then the venous system. So those definitions are important because we begin to use those terminologies quite frequently and regularly throughout the lectures. May I then quickly begin looking at the flow dynamics so that we can then get to the details of our lecture this evening. So how do we apply the physical law of F is equal to delta P divided by R in relation to the flow patterns of flow dynamics in the vascular system? Number one, the F in that formula will represent cardiac output, which we normally abbreviate as capital CO. And then the second part that we need to explain in more detail is the driving pressure. That is the hydraulic pressure that drives blood through the vascular system. Now, remember, this pressure is not a constant. It will vary from the left ventricle, the aorta. It will vary through the large caliber vessels like brachial artery or femoral artery. By the time you get down to dorsalis pedis, then obviously the pressure will be quite different. So what we try to do in order to be able to get what would be a uniform figure, we measure what we call mean arterial pressure. In this context, in these slides, it is abbreviated as PA, and we did this abbreviation for recognition. This information is obtained from some of your reference books, but may I quickly request you that where we have a PA in this formula, use MAP. That is more of the standard abbreviation we use both in basic physiology and clinical practice, so that we can carry the same uniform abbreviation throughout. So we have MAP, which is mean arterial pressure. We'll abbreviate this as PA. So it is the difference between mean arterial pressure, which will be a representation of P1. We need to get then the representation of P2, and P2 will be represented by the pressure in the right atrium. And the pressure in the right atrium, we refer to it as central venous pressure. So that will represent our P2. May I repeat, P1 will be represented by the mean arterial pressure because using the pressure in the left ventricle or aorta will be erroneous because we do have significant pressure all throughout the arterial system. So we prefer to use the mean arterial pressure. We'll be coming to define mean arterial pressure later. I want to stress very strongly here, it is not the average pressure. This terminology is used very differently to denote a pressure measurement in relation to systolic pressure and diastolic pressure. We'll be coming to that in subsequent lectures, but for purposes of calculation, P1 will be the MAP and P2 is going to be the CVP, which is the central venous pressure. And then the third part of this formula is the resistance, in which case, in books of physics, we talk about resistance, but because we have a large vascular tree in the human body, we have different levels of resistance exerted on circulation at different points. So we prefer to talk about total peripheral resistance, which takes care of cumulative values of resistance all across the vascular system. So we abbreviate that as TPR. And therefore, based on the formula that we talked about earlier, F will be CO, which is cardiac output, will be equal to P1 minus P2, in which case P1 is going to be MAP minus CVP, and we divide that by TPR, which is the total peripheral resistance. May I quickly then give you some values to remember. The central venous pressure in general is, the value is noted to be 0 to 5 millimeters of mercury. So for purpose, we'll take the lowest value, which is 0. And if we replace that or substitute in this equation, we have MAP minus 0, and therefore cardiac output is going to be MAP divided by total peripheral resistance. But remember, MAP is the representation of the blood pressure, because we're talking about blood pressure in this context. The mean arterial pressure, or PA, represents blood pressure. And therefore, having agreed that central venous pressure will take the lower value of 0, therefore, if we, in this formula, cardiac output would then be equal to MAP divided by total peripheral resistance, or PA, which is MAP, will be equal to cardiac output times total peripheral resistance if we go by the basic rules algebra, making MAP the subject of the equation. And MAP usually represents blood pressure, and therefore you need to recognize what we have done from basic laws of physics is to create a relationship between blood pressure, cardiac output, and total peripheral resistance, and stating clearly that blood pressure is equal to cardiac output times total peripheral resistance. I do request that you reflect on this, because examiners love to ask students to explain these relationships. I'll go ahead and give you some homework. I'd like you to read through about Bernoulli theory and law. Some of you who did physics, you covered in either physics or mechanics part of mathematics. And those of you who didn't cover that, you read through this, because it helps us to understand other flow dynamics later when we begin looking at flow through the system. So I thought I should exclude this to avoid mathematical equations and more complexity at this particular stage. We'll then move to look at another aspect that will allow us to understand the behavioral flow of blood in vessels by looking at 3 different flow patterns, namely laminar flow, turbulent flow, and single file flow. Laminar flow usually is described as flow that is silent. And this is what happens in a vast majority of the vessels in the cardiovascular system. And that's the reason why when you're seated in any quiet room, you do not hear the circulation noise through the vascular system next to you or sleeping next to you. It's because, generally speaking, the flow is silent. It happens in normal arteries, arterioles, venules. It happens in veins. It also happens in smaller caliber veins, such as the vessels. One thing to recognize, however, is that if, for instance, you put pressure or you compress a large vessel, good example is a brachial artery or even the femoral artery. If you compress it to a level where you disfigure the aperture or the lumen of the vessel, then in fact you convert laminar flow into noisy flow, so that if you put a stethoscope over the vessel that is compressed, you actually begin to hear some noise. And that's the principle we use when we measure blood pressure. You did the practical last year. If you didn't do it, we're going to repeat that again so that you understand the principle used to measure blood pressure. We convert laminar flow, which is silent, by compressing the arteries, especially the artery. And once we compress that vessel, we then introduce critical pressure. And that allows then laminar flow to become noisy, and that noisy flow is what we refer to as turbulent flow. It is noisy, tends to occur in vessels that are compressed. It also occurs in ventricles because blood flow through the ventricles navigates through sharp corners. This is common really in younger people. So we get extra noises over the heart above normal heart sounds. Those extra noises are the ones we call murmurs. That is M-U-R, M-U-R. We'll cover that perhaps in lecture 3 or 4 of this series. And then finally, we have the normal single file. And this normal single file usually refers to flow through capillaries. Just remember from the English language dictionary or synonyms of a file. File in this context refers to a line, so that if, for instance, this area here formed the capillary tube, remember that the diameter of the red blood cell is bigger than the diameter of a capillary, and therefore the red blood cells tend to change shape or configuration to be able to navigate through a narrow tube. And that's a process we call. So the red blood cells, in fact, will lie one after the other in a file or in a line. And that is why this particular flow pattern is referred to as single file. I'll then move to another set of slides just to explain what I have explained so far. That is looking at laminar flow and also single file. In terms of laminar flow, if this is the tube and this is the red blood cells along the wall of the vessel tend to be subjected to much higher resistance, and therefore their velocity is reduced. That's exactly what is explained in this particular diagram. However, the cells in the middle basically have less resistance, just resistance created by cells lying next to each other or floating next to each other. So they tend to move much faster. This is what we call parabolic profile. That's a kind of flow pattern that we experience in small, middle, and large caliber vessels. And of course, what is described below here is what I did explain about single file, where you have small red blood cells that change shape to be able to navigate through a small caliber capillary. That is what we refer to as diapedesis, but the flow pattern itself is referred to as single file. I'll spend a few minutes just to look at flow patterns. We'll look at flow patterns or how to measure blood flow. This is very different from how to measure cardiac output or how to measure blood pressure. In this context, we're just referring to flow. Blood flowing through a blood vessel, could be an artery or a vein. We can use either invasive methods, which means that we introduce a needle or a catheter directly into a vessel and do the measurement. We can also use non-invasive methods. That means that we take a device, we put the device over a vein or an artery, and we can be able to measure the flow pattern through the device. What I'm describing here is a mix of both. Some of the methods are already not in use. Others have been modified through technology and applied in clinical practice. But it's important that you be aware of the older methods and the newer methods. So first is the electromagnetic flow meter. Just the way the word suggests, electromagnetic flow waves are used to try and determine the flow in the vascular system, either veins or arteries. The second one is Doppler flow meters. These Doppler flow meters, we use them every day. Even this afternoon, I was using a Doppler flow meter to determine blood flow through the legs and the neck of a patient. So it's something that we use quite regularly. And again, I'd like you to make a footnote on this slide so that you can read about Doppler. Doppler, in fact, comes from a name of Christian Doppler, who lived many years ago in Austria. Vienna is the one who discovered this method. It's a very intuitive method to the extent that when you read, you'll actually be fascinated by just how basic observations led to major scientific discoveries. Doppler is used by medical doctors. It's used by hydrologists when they're looking for water in desert areas. You send ultrasound into the Earth's surface and you try to get responses, and from those responses, you can be able to determine whether there is water or maybe. So very, very useful. We use this every single day. And then there are indirect methods, fixed principle. Some of you who did advanced biology, you may have come across that in high school, and then PAH, which is the para-aminobutyric acid. Again, I invite you to read more about this. They're well explained in your reference textbooks. We have two other used less body in example. So they are venous occlusion, ethysmography, and KT's tissue clearance method. This is part of homework, read more about for purpose of expanding your knowledge. We do ask questions about this, not deep questions, but just to reflect on the fact that you have a good understanding of the basic physiology. We shall then move to look at the behavior of blood flow in arteries, which we call hemodynamics. But then we'll begin with definitions. The first definition is to look at capacitance. Capacitance in this case, we refer to vessels that hold a large amount of blood. There's vessels that have a large capacity. So capacitance vessels in this context would mainly be veins. They hold about 50% of the circulating volume. And again, as part of your homework, I want you to go and find out how much blood, you may have covered this during your blood physiology, but how much blood a human being has in circulation. And just remember, from the figure you get, 50% of that is resident in the veins. Then we have resistance vessels. As the word suggests, these are usually small arterioles and arteries, and they are principal sites of peripheral resistance. They exert the highest pressure resistance onto circulating volume. And I'll show you a diagram just to demonstrate how important that is. And then finally, we have two other definitions, that is a high pressure system and low pressure system. And I think, as the word suggests, high pressure system is usually the arterial system, and low pressure system would be the venous system, including the pulmonary circulation, that's circulation through the lung, the heart chambers, of course, except the left ventricle. Left ventricular pressure is normally higher. All chambers tend to have a low pressure. So with regard to extending our knowledge in terms of hemodynamics or behavior of flow in the arterioles, I want to look at the arterial waveform, and we'll be ending our lecture the introductory lecture quite soon, so that once we understand these dynamics, our next lecture will then look at how we measure those pressure waveforms to be able to detect systolic pressure, diastolic pressure, and from there, accordingly measure mean arterial pressure. So it'll be a nice point to end this introductory lecture. Many of you have visited intensive care units or high dependency units and seen monitors. Those sometimes impose some sort of high technology and fear amongst people. But in fact, the knowledge on the information you learn today will simply allow you to understand what goes on that monitor. It tends to be an arterial waveform, and this is exactly how the waveform will look like on a monitor. If you haven't visited a hospital recently, some of you watch nice movies. During my time, we used to have a movie series called ER. I'm not sure what exists, but it does show you a lot of scientific stuff on the screen, so it makes you understand a few things much better. So in general, if you were to take a Doppler system and put this over any artery, could be carotid, large caliber vessel, brachial artery, femoral artery, you actually get two blips. So you have that blip over here, fast blip, and then the pulse would disappear at one point, and you get another blip. In fact, if you are to feel your arterial pulse now, and I'm trying to feel mine at the moment, you should be able to get some sort of pulsations. So the pulsations will be at the peak over here. And this peak point pulsations, in fact, is a transmission of the high pressure all the way from the left ventricle. Thank you very much. So this is the transmission of the hydraulic all the way from the left ventricle. So let's go through the literature right in front of us so that we can be able to understand this much clearly. Please mute yourselves. Please mute yourself. Thank you. So the arterial waveform usually is the fluctuation. That's the figure that I showed you over here. So you have a fluctuation from baseline. So literally speaking, we say this is relaxation phase of the left ventricle. It contracts and generates a pressure in the ventricle, pushes blood out, and that hydraulic pressure is transmitted all throughout the vascular system. And then that dies out waiting for another contraction. So you have an oscillation like that. And that oscillation is important for us, especially when we study the vascular system, to know that the vascular system is working optimally by just looking at the heights and that particular waveform. So the waveform usually is due to the volume and speed of ventricular ejection. And one of the things I want you to appreciate is that not only is it due to volume and speed, or maybe reflecting the fact that if you had less volume in circulation, like if a child who is dehydrated because of diarrhea and vomiting, somebody has bled out of an accident, the volume will be reduced. So we expect those troughs and peaks to be reduced in intensity. So the other reason is the rate of runoff through resistance vessels. So if the resistance is quite marked, then obviously you would expect the peaks and troughs again to change or to vary considerably. And then the other aspect is arterial wall distensibility from anatomy. The arterioles have got smooth muscles, and therefore that allows them to distend. And this is a phenomenon seen in younger people. As people grow older, from the age of 50 or 55, that distensibility is reduced. And therefore, again, it changes the arterial resistance. But the point to mention is just the pulsatile flow. If you feel your radial pulse, it sounds very simple, that the pulsation really is because of hydraulic pressure transmission from the left ventricle vascular system. But in fact, the truth is that pulsatile flow is not well understood. So there are lots of things that we still don't understand. This is a closed tube that is circulating round and round. So there are a few other aspects that are not clearly understood. And I complete this lecture session by saying the following. At the bottom of this arterial waveform is a pressure, and that pressure is what we refer to as diastolic pressure. And at the peak of the waveform is a pressure measurement, which we refer to as the systolic pressure. Now, the two figures, 120 and 80, have been used for purposes of illustrating what you know from high school. But we'll be coming to redefine normal pressure and optimal pressure. 120 over 80 is what we refer to as optimal pressure. You were taught in your younger years in primary school and high school that is normal pressure, but in fact that is not true. It's what we refer to as optimal pressure. Remember, all physiologic measurements are a range. So blood pressure is a range, like temperature or any other physiologic parameter. But we do use 120/80 to explain a concept. But we retain that 120/80, as I did say, as optimal blood pressure, not normal. So you need to drop the description of normal blood pressure at this point. Now, when the waveform begins to decay and come back to the normal level and back to the trough, at this particular point, if we are looking at the aorta, what happens is the aortic valve closes. When the aortic valve closes, when the pressure is decaying, there is a tendency of blood within the aorta to try and flow back into the ventricle. And it's met by a closed aortic valve. And in the process, there is a small increase in pressure, which we then refer to as a dicrotic notch. Just remember to understand the physiology behind this little bump, which signifies pressure increase in the aortic root as a result of closure of the aortic valve. This little pressure increase is important, mainly because the flow into the coronary vessels tends to occur during diastolic phase. So it's good that there's a tendency for backflow, which then increases pressure around the aortic root. And in fact, it's at that point that there is good flow into the coronary vessel. So that is the usefulness of recording a dicrotic notch. This will not be there if the aortic valve is not intact. Two other concepts I need to leave you with as we build onto the concept of mean arterial pressure when we come back is the broken line right over here is what we refer to as the mean arterial pressure. But in fact, if you look at that, it's not the average. One would have expected that the average should be in the middle of 120 and 80, someplace over here. It's not. So the mean arterial pressure in itself is not the arithmetic mean between systolic and diastolic pressure. That we're going to define more in the subsequent lecture. What I want to leave you with is the difference between systolic pressure and diastolic pressure is what we refer to as pulse pressure. And we will be using pulse pressure, systolic pressure to help, and diastolic pressure to help us understand what we refer to as mean arterial pressure. I must leave it here so that when we get our next lecture, we'll begin at MAP, or mean arterial pressure, what it means, and why it's important for us to measure mean arterial pressure in clinical setting rather than measuring systolic and diastolic pressure. Many, many thanks for your patience, and I must say my condolences to losing a classmate. I learned about this today, painful so. I hope you all condole the family and messages to them at this particular difficult time. Thank you very much for your attention.
Atención.